Hip avascular necrosis. Avascular necrosis means death of the bone with interruption of blood supply, classified by Steinberg, modified by Fickett and Arlett, JBGS 1995. Stage 0 is normal X-ray and normal clinically and normal MRI. Stage 1 is a normal X-ray but abnormality on MRI or on bone scan. Stage 2 is when there is X-ray changes, cyst and sclerosis and osteopenia. Type 3 is crescent sign, which shows subchondral collapse. Stage 4 is flattening of the head and collapse. Stage 5 is joint narrowing and acetabular changes. And stage 6 is osteoarthritis. Regarding the cause and risk factors, it is alcohol, inflammatory bowel disease, idiopathic, radiation, hypercoagulable state, hematological, iatrogenic, and trauma, and decompression and Gaucher disease. Regarding the prognosis, small lesion, best prognosis, larger lesion, bad prognosis, sickle cell disease, highest progression, steroids, bilateral involvement, SLE, more benign course. South Korean study showed that small lesion, 5-10% of involvement, will progress 30 will less than 30% it had involved. Monitor if asymptomatic. Larger head, more than 84% chance to progress within 5 years. So if there is any collapse, subchondral collapse, THR is an option. Regarding pathogenesis is not fully understood. Some of the important concepts are thrombophilic theory, not thrombophilic theory, intravascular coagulation and vascular occlusion, hydrostatic pressure theory due to increased venous pressure, lipid deposition theory leads to increased pressure and fat emboli, vascular theory occlusion of lateral circumflex femoral artery, primary cell death, and abnormal mechanical stresses. In decompression disease, the dissolved gases come out of the solution into bubbles inside the body on depressurization and hampers the blood supply. Regarding investigations, I will do X-ray and I can proceed for MRI scan. In X-ray, I want to see the involvement of the head with the bone density changes and subchondral collapse. Regarding prognostic factor with the head X-ray, a Kerbal angle is important. A modified Kerbal angle, necrotic angle, is taken at mid-sagittal and mid-coronal MRI scans. These two are added together. If less than 30 of femoral head or combined necrotic angle of less than 160, low risk of collapse. More than 50% involved or more than 200 degree, high risk of progression. In MRI, you will see dark T1 images, decreased signal intensity due to loss of fat marrow, and T2 bright density due to marrow edema. Regarding the pre-collapse cases, 0 to 1, protected weight bearing, biphosphonates have been advised to prevent collapse. There is other pharmacological agents like lipid lowering agents like ionoprost, core decompression like relieve intraosseous pressures, improve the blood flow, drill 8 to 10 mm hole through the subchondral bone. It pass 3.2 mm pins into lesion 2 or 3 times is also possible. Failure rate of 20%. Fairback showed that 10-year survival with core decompression stage 1 is 96%. Adjuvants can be stem cell, bone graft, or a fibular strut. Fibular strut can be vascularized like urbanic or non-vascular. Then there is a transtrochanteric Sugioka transtrochanteric osteotomy, which helps to change the weight-bearing action of the area. Trapdoor technique is just discussed for the historical purposes. It is done by the safe approach of the guns. Regarding the collapse, total hip replacement, poor results with hip revision rates in sickle cell, renal failure and transplant and Gaucher disease. NGR nowadays shows cemented total hip replacement have improved results because of the better cementing technique and XLPE liners. Resurfacing require adequate bone stock and no deformity, not for steroid or renal disease. Arthrodesis is considered for young age. Idiopathic transient osteoporosis of the hip, when the head and neck both have diffuse changes like AVN. Treatment is protective weight bearings for 6 to 8 months.